Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator, and this is session number 204. We have a complex coronary left main LAD, probably moderate to heavily calcified lesion today to demonstrate many tips and tricks for you to learn and hopefully with some imaging guidance as well. With this introduction, let me take you to the cath lab where Dr. Sharma and Dr. Kinney are standing by. Sameen, Anu, good morning.
Good morning.
Week of the symposium as well.
And this actually happened to be, since it's a truncated week with the 4 days, Friday is a holiday, so we started our hemodynamic session today. And we have 50 young aspiring candidates, fellows, resident or international fellows, some junior attendings in the audience, 50 in the our Hatch auditorium, and I encourage them to ask any questions also related to this case. Now, this case, although looks very description-wise quite complex, but it turns out to be maybe simpler. We wanted to, because we have another case later with the impella-guided intervention in a complex case, which is part of the hemodynamic conference. But we thought this is a great educational session, and we should show everybody what we have. Anu, just say hello to everybody, and our staff, basically myself, Anu, and we are two, our interventional fellows, Sophia and Monica. Monica will become the international fellow next year. Then nurses Will and Kim, and CVT Asif and Hakim. Imaging is same Kiski, and rest of the staff you'll see in and out same people, and that actually remains consistent. Commercial support for today's is by all these people. As you know, the font size is uh, according to their contribution for this great educational event. CCC live cases, learning objectives remain the same, and we are so happy that BroadMed AV is our the preferred partner for relay of these cases, which have been tremendous, and of course, three of us with no different conflict of interest. With that note, I just want to start this patient, 70-year-old, class 1 angina, CCTA revealed 3 vessel and left main disease. Then patient for stress echo, but due to limited exercise, pulse rate just went from 80 to 95 and non-diagnostic. Has normal LV function. On the left side, you see the control factors that have PAD. SAQ score was 93, means just mild symptoms, because higher the SAQ score, less the symptoms are. As far as the control of the CAD risk factors are excellent. LDL, maybe we need to bring it down to 55 because we increase the dose, or torostatin, which used to be 20 milligram before, we made 50. Patient already on Zastoratic and amlodipine with aspirin, and cardiac cath done. At that time, revealed left main CAD. See, distal left main trifurcation, but individual segment. LAD, circ, and Ramus has no disease. There is additional disease of the LAD diagonal bifurcation further down, and 80% RPDA. Normal ejection fraction. That time we did a stent of the PDA. We'll show you that. And patient discharged on clopidogrel and added metoprolol daily. And now today is this distal ligament trifurcation and LAD diagonal lesion. This calcium is only mild to moderate. So we decided that with the plaque modification will be done by the imaging. And of course, we decide whether 1 stent or 2 stent. This is our grid of the left main based on the complexity. So this will come out to be on the 3rd category, because syntax score, despite trifurcation itself, even one disease vessel take you to 26. This is 21, as we see, concurrent multi-vessel disease of the LAD and diagonal. So it remains appropriate whether PCI or cabbage. Actually, that circle should be on the PCI arm, because patients on dual antiplatelet therapy, dual anti-ischemic therapy. And tell us what's happening now from your side.
So this is the right coronary artery. You see that? Looks very good. The stent in the PDA, and then left. So definitely, I don't know. Can you put the hemodynamics in the bottom? This is a 6 that you see this ventricularization of the pressures. It's a good, our hemodynamic app shows all these kind of cases when it's ventricularized, and in that situation, it's you have to make sure the costume of the circ looks okay. Even before we give dye, do do see some calcium, probably mild calcium. Adventitial circ looks okay. This is RAO view. Again, circ and the branches are okay. The question was, we were talking trifurcation. It is more, I would say, the branch of the LAD, so the diagonal, not the ramus, true ramus. And then RAO, you don't see a true LAD going all the way to the apex, short of the apex, because the right coronary artery PDA is reaching the apex. And then you have in your cranial, your first diagonal is okay, but the second diagonal is the one that is diseased, and at the level of the second diagonal, there is LAD disease, small size LAD. So now we will image to understand the left main and then understand the LAD. So even if we see there's LAD disease, since LAD itself is small, it's almost a dual LAD, D2 to D2, and LAD that do we go from, if we need stenting, we go from LAD to diagonal, a single stent, and then stent across LAD to left main, since the circ is okay.
Why not just the LED stenting after the left? I mean, first the LED and cutting balloon of the diagonal.
No.
Yeah, why not? See this there? Cutting balloon of the diagonal, because there is a lesion after that LED diagonal bifurcation. A mild disease.
No, mild.
Yeah, mild.
If you see the length of the lesion of the diagonal is longer, more than 10 millimeter,
Give a little more
compared
nitro.
to the, we did.
No, where? Give more. I'm saying
We're
this
thinking
one,
about it.
vessel will become more with the, and you have 6 French actually. If we have to do, we have to do a reverse crush or so. Let's see if
No.
we have some. Okay.
In
Take a better picture now. with the
question
nitro.
for you here.
Yeah.
In addition to imaging, is there role of functional
Yep.
assessment with FFR?
I was just going to say that this is the type of case where will be, and this is one of the presentation will be, that which case you want to do both imaging and functional. So this is a type of case, unless left main clearly says less than 3 millimeter square on imaging, I think you have to combine with physiology.
Right.
We are to physiology of which area?
No, physiology, maybe after you fix the left main or pull back, that is there a gradient at the level of the LED is very difficult to do unless you have IFR.
Yes.
IFR still can localize, but current FFR will not be that diagnostic.
Okay, so if you see, the lesion in the D2 is significant, right?
Yep.
LAD is also significant. Left main, if actually after we give nitro, it got ventricularized more. So let us just image first, okay? Kiski, do we have the slide of that guideline when we do left main PCR? With after that we go do the FFR. Remember we presented it during our imaging live case, so we can present it to our viewers.
Welcoming a few viewers from Jakarta, Indonesia.
So I need to check 1 second.
We are finishing our fellowship training this month, and new fellows will start next month.
Good luck to the finishing class with their ongoing careers.
Yeah. I will have 4 women fellows.
Wonderful.
Okay, trained this year. Now Sophia, fully trained, she'll be going to her, joining her husband, who is also interventional cardiologist. Now Maria, who is training structural, she'll stay here. Sabina, who finished interventional, stay as a structural. Swati, who finished her second year of, training, interventional, ready to do all complex procedures. And Monica will stay here for 1 more year.
In the entire structure of not only women in cardiology, women in interventional and structural, totally based here.
Yeah.
From the teacher to the students, the entire gamut, and I think it deserves recognition.
Are you pulling back?
One sec. No, no, no. It's not on the screen.
Huh?
Okay, start
Okay, we
pullback.
have it now.
Yeah.
Coming. It's a mid LED. Here, no plaque. These are diagonal, some branch. Focal calcium, but mostly non-calcified plaque. Flux LED. Oh, very short left main. I will stop it.
Left main is short.
Or maybe guide is engaged. I
No,
will
no,
check.
no. Guide is outside.
Okay. So, oh yeah, I see. So now this is the level of the aorta.
Yeah.
Now go inside. This is the ostial left main.
Okay.
Left main has some eccentric plaque.
So what we are seeing is the size of the left vein is small. There's no true plaque, right?
Yeah. So this is you see that from 2 o'clock. This is
Yeah.
the first bifurcation. So this is the circ. So now come proximally. So this is a distal left main. Yeah, there is some eccentric plaque, and here.
Yeah, but plaque is not a lot. Look at the vessel size. The
Yeah.
size of the vessel is small.
Yeah, 4.1 vessel,
Yeah.
and a plaque burden 66%, and MLA, like minimum lumen area of the left main, is 4.6.
Okay.
So like around.
That's where the distal.
This is a distal left main.
Okay.
Then come inside. Now this is the after the bifurcation ostial LED.
Okay.
Some diffuse, but no calcium. Yeah, here is some focal calcium.
So there are two Ds, right? D1 and D2.
Sure, I check again.
So where is that lesion?
Now the circ come from the 2 o'clock, so the
Yes.
diag it should be come from the same direction. So this is the initial big branch. So this is a D1 just
Yeah.
after the circ.
That looks okay.
Yeah.
Keep
then
going down.
Yes, go inside. Yeah.
Okay,
so
that's a level of
yeah,
D2.
Yeah, this is a D2. This
Yeah.
is a level of D2.
Yeah, and so
it is correct. After the D2, there's some plaque and but vessel side chain. After the D1, D2, the vessel size is 2.7, and a plaque burden 50%, cross section 3. So huge size gap at 50% plaque and a cross section area 3.0 after the
D2.
Yes.
But there's disease before D2 also.
Yes, like
Come back.
diffuse eccentric.
Yes.
Plaque.
See that? Yeah. Yeah. That's at the level of the D2 there. Yeah.
This is just before proximal to the D2.
So it's more of a fibrotic lesion, some calcium, right?
Yes.
Yeah, more of a fibrotic
Very
lesion.
focal calcium and fibrotic, and some part is like attenuated plaque. This is a lipid plaque. So mostly fibrous and lipid plaque.
Okay, so what we can go back and teach the viewers the image. So go back, so you see what's lipid, what is fibrous. Okay.
Yeah.
So
yeah.
you do see there's calcium specules. Why do
Yeah.
you say it's calcium? Because you don't see behind.
Yeah.
Yeah. So go back to the fibrous plaque. It's bright.
Yes.
Yeah, right there. Yeah. Okay.
Yeah, like this is fibrous plaque similar to the adventitia.
So now the question comes, I mean, with this kind of a tight disease, I don't know, we still need to do FFR? I don't think so. Go back to the diagonal. The question is, how are we going to deal with D2? What do you think, Samir? The question is, right, do we take care? Look at the D2.
I think you should. To me, the real question is the left main.
Yeah, now I'm thinking of, do we just, I would plan in such a way, put one stent all the way from left main to D2. Cut the D2, left main to D2, leave the LED alone. That's one option. Somebody may tell, okay, stent into left main to LED, consider only cutting balloon. But I think in this day and age, you should not just leave it with cutting balloon. We could consider DCB of the D2 and then stent across LED. That's another option. Yeah.
Yeah, I think no. I mean, it was all right to address a question posed by the audience, but I don't think we need to go into a functional analysis based on the information which you have.
Okay, good. So now we will wire D2, and then I'll go with the fielder wire D2. Let's cut it and
I
then
think
make a decision.
Samin's initial assessment was correct that the lesion appeared a little more easier than how we thought initially, but again, that could all turn out to be totally different.
So seeing this lesion, I think we can just do regular balloon, right? You don't need to do a cutting balloon, or we can use the same cutting balloon. Actually, the die cutting balloon size will be 2 to 5, right? Open to, yeah, I'm going into D2. Have you uploaded those slides, Kiski? Okay, some die there.
The recent one, the EVC 2026
No, not that.
consensus.
Our
The king, do you want to show this one? So, and after we click, the reason why this is not the robust evidence.
yeah, if you have this is the recent publication that has come out, but what I meant is there's no definite what I would say publication to support this, but I'm just showing it to say when you have left main or any borderline, means there is a definite cutoff. The usual cutoff is 6. If you are above between 6 to 7, you can always do a FFR of the, yeah, not that the other slide. You don't have? We are going to go 2 to 5 of the diagonal now. Let's get the D2. And we will use the same balloon to do the cutting balloon of the distal left main. Okay.
You know,
Okay, good.
just around there where you were getting stuck was a
Yeah,
focal
significantly same.
calcification,
Yes. Good. Go.
which I think will need to be addressed. I don't think a stent will
14, 16, 18.
swing through there.
Okay, down. Go up here. Okay, good, down. So distal left main, go up here. This is only 2 to 5, but still I think will be okay. Down, yeah. Now it's go. Yeah,
Yeah, went through much easier, I think.
Yeah.
That little.
Okay, down. Let me use that, do the LED. Ready?
Looking good.
I think we can do the left main to LED stent. I'm going to use the same cutting balloon to the LED, okay? I will put a 3O, low pressure, okay?
Yeah.
From the question is, we don't need to cover the ostium, right, Kiski?
No need. Osteo left mains, some plaque with areas like 8, 9.
Okay.
And a huge size gap because left main vessel size is for low.
Anu, I hope that the real, as I watch this case, there is one which is probably the biggest teaching case of any, and trying to do any of this without imaging is shooting blindly. I mean, you really need to, everything changes based on what Kiski just mentioned, that stay away from the ostium. No reason to mess around there. The issue is as guided by imaging, mainly in the distal left main, some concern in the ostium of the LED, but not much.
No, I disagree. Look here. Why I said so? Look at the angiogram. Look at the ostium of the left main. Is okay.
Yeah. Looks okay.
Yeah, yeah. So, you know, if there was no imaging, no key, I would have
You would
just
have
done
proceeded.
the,
Yeah.
yes,
Yeah.
yes.
But look, Anu, there's a huge difference between very experienced operators who are
Well,
able to discern that, and I think overall imaging guidance will help here.
no, but remember the recent ACC publications, both were
Absolutely.
negative, down. Yeah,
Which
so
is the reason for my bringing up the topic. But
no,
this is
what we are
all.
trying to say is that there's no need to overdo it.
Mhm.
Okay, down.
This was the same
Overdo the imaging. Yeah,
2.25.
yes. Okay, go up here again. So we can go with the only reason I'll be using 3.0, but is, say no, the LED is too small there. Okay, let's take a picture. Looks good. What does he feel about? So what we teach is normally if you're going to do anything of the side branch, if you're going to do provisional stenting, side branch intervention has to be the last one. Okay, so that is something we went opposite. So now we have to do something to the diagonal if you're doing provisional stenting. Where is it? That Dr. Sharma planned to join us, or I finished the case?
Diagonal almost the same size as the LED.
That's the
pretty
reason
darn
I'm
good.
saying why we should do something. At least
I
let's
think
do a
something
cutting.
needs
I
to,
mean, let's
yeah.
do a DCB of the side branch. So we feel that we've done, you know, some treatment. Agree? Now the question also comes is that if we are doing DCB of the side branch, we have had this discussion. Do we do it before stenting or after stenting? So the both option is possible. So let us do one thing. Let's go back. Long balloon 15. Get me a 2515 balloon.
Yeah.
Let's do that, and then we do DCB and stent across. Okay, give me.
Anu,
We made the decision.
overall, what do you prefer in such cases? Do it before or after?
We have tried both.
Mhm.
So if we do it before, we finish it before. So there are a couple of cases, then we actually lost the side branch, and then we had to recross case, which then the whole thing. Yeah. And many times we say we do it afterwards, and after we stent, side branch looks good, and then we have left it alone. So unless we have systematically done it, because there are, I think, few more studies are happening right now, bifurcation, and we need to know exactly how this treatment happens, we will not have an answer. What I like to do is we did a cutting balloon. I like to do a regular balloon for long, like 90 minutes, 90 seconds to 2 minutes. And then after that, we will do the DCB of the side branch, and then we stent across. Because once we do the DCB, we do not re-enter that area. Okay, go up. You see this now? We'll go low pressure, just like a good old balloon, the POBA 4 is good. Down. Let me go in a little bit more. And always when we do a DCB, I'll take a longer length. So I would go, what do you have here? 25, 20? Give me a 20. And then we will do low pressure, leave it. Start the timer, 90 seconds. And we will take a stent from left main to LED. We are only very low pressure here at 4 atmosphere.
Anu, there have been some questions which came today, I think prompted by introduction of the fellows and that topic. Specifically, how long is the interventional training?
It's 1 year.
Yeah, that's what
It's
I told them.
ACGME is 1 year.
No, because you mentioned about Swati staying second year. I think that's what prompted the question.
Okay, so what happened is she wanted to
Stay
do
annexed.
extra training with the means. Remember now they call it CHIP.
Mhm.
Mount Sinai Fellowship is a CHIP by itself, because at the end of the fellowship they would have done close to 100 atherectomy cases. They have exposure to atherectomy, IVL, bifurcation, large bore access with use of MCS. They even scrub in some of the few of the structural, like if you're doing BAVs, septal ablation, they get exposure to peripheral, they get training. So it's almost a CHIP fellowship. Once they do a fellowship here, they don't need another year. But she actually wanted training in CTOs, bifurcation, and she actually has done very well. Yeah,
And
yeah, down.
ECMO proficient?
Yes, she is. Go up. Good. Right now what's happening is everything is becoming a subspecialty down. And no. When this is done, because what's happening is there's a lot of talk in these big meetings about training women. People don't stay in this so-called I would not use that word, but I'll be forced to use it right now, male oriented field.
Look,
Uh,
it sounds politically incorrect, but it's absolutely true. I mean, if you
Yeah.
just look at the statistics, they bear out.
They wear out.
And
It's not
I think
because of that. I think it's the politics of everywhere. It's not just medicine.
besides, but I think there has to be a sustained effort to break through all these barriers one by one. And I made a special mention of what you had stated here, that's happening here, and I think it needs to be encouraged.
Yeah. I would go, the question is, can we go 275, 33,
There are little
and then post dilate it?
dissection in
Yeah.
the inferior part of the left main there, or is it just
No, it's just
nothing
a
there?
thing. Yeah. I'm
Like
not going to image.
calcification there.
Yeah. What do you think, Kiski?
Yeah, from the body of the left main to that septal is 28 millimeter.
No, I was thinking 28, we barely will make it. So you need a little longer.
It's like side by side. 28 is side by side. But if we go distal to that septal, the vessel size is like 2.6. Yeah, like size gap.
Mm.
And actually, the left main follow vessel, the lumen 3.5. Of course, left main, the 3 of stent is too small.
I don't want to put 2 stents.
Yeah,
So,
because the lesion length is not that long. So
the question came here, why didn't you use the radial artery?
Oh, yes. Why not?
Hmm?
Yes. Excellent. Yes. Radial fans can go radial artery, but high volume proceduralists like me, every month I get a notification that my radiation is high. So I have to cut down. And highest radiation is when you do radial because you are closer. But yes, nobody talks about that. Yeah. Good. All this. Yeah. Good. 4 is good. Yeah. Yes. Good. Okay. Okay. Start the timer again. You did it. Yeah. So again, you see that we have a little bit in the main
LAD.
vessel, which is again, we will say that if you have DCB and then you're going to stent is there's a double drug dose, there's a risk. But I think since the always Achilles heel is the ostium of the side branch, it's good to make sure the ostium is fully covered. That's why you take a longer balloon and then low pressure. We are only at 4 atmosphere and we are going to go for 60 minutes. We are going to stent across.
No, go to 6 atmosphere at least.
No,
That's nominal.
This is barely, the vessel is 2.5.
And
Already we took a 2.5.
This is 2.5?
2.5 DCB.
Yeah, then should be 6. Because remember, less if you're not against the vessel wall.
It is
what they want a
the
minimal, nominal. You have to go to nominal of the DCB should not be big, go to 6 atmosphere. So key the nominal, the science behind is that drug, the stent of the balloon with the drug has to come in the contact. That's only it will diffuse. That's the key. And this is the whole science about the lipophilic and non-lipophilic. is the whole issue. The saga is going on now, whether it should be paclitaxel versus sirolimus, because we are very close to have a sirolimus DCB approved with a solution by the Cordis now, which has been taken up.
I mean, maximum diffusion should occur at the nominal size, no?
Nominal. That's why I'm saying they cannot go to 4. Has to be nominal balloons. Some are 6, some are 8. You have to
Right,
look into it and to go there. Yeah. Some people used to do 30.
Okay.
So what is the plan now for the
Now
LED?
we are stenting LED. The question is
LED
32
where?
versus 33 from the septal up to the mid left main.
And Austin left main different?
Austin left main, we are not doing anything. There's no
No, but
disease.
Austin left main you engage. It's
There.
It become damped completely.
Yeah, but this, look at the size.
No, but I think it's eccentric.
No.
You touch. Okay. 6 French guide. Let's take this one out first. Touch the guide to the ostial, and you will see classical dampening. They're telling you that at least there is a 50% lesion. Whether you can see eccentric. Remember, IVUS is notorious, including CTA, for ostial left main. Good. Connect. If we live show the hemodynamics scene. Good. Just connect there. Attach. You are in now. You are there attached or no?
Yeah.
Earlier
Yeah.
you had damped earlier, not now. How? Little die. See that you are in.
So, Samin,
Yeah, good,
more, I
fine,
think
good.
this matter
Very good.
requires further clarification.
Yeah.
That now we have imaging showing that ostium is really not involved, whereas your point about dampening happening also is showing almost a physiological aspect. How do you discern between the two?
No, but I think now, remember it was earlier, as Anu just demonstrated, there's no dampening now. I think part of that was no vasodilator was given at that time. We did have dampening in the beginning, but now there's none. So you can spare the ostium, and that is confirmed by the IVUS.
Yes,
Good.
yes.
Put one stand now.
No, so I think you want 33 or 32?
No, 33. Right?
No, this is 2.5.
Yeah.
This is 4.0. He's saying 4.0. I would not go 4.0.
No,
Yeah,
It's
3.5.
probably
full
3.0.
volume is
You can
I
put
want to
3.0.
put a 3.0 between the septal to the mid body, which will be
And
give a
proximally
33.
you can dilate to 3.5.
No, I would not give 3.0. We go 2.75
Okay,
because LED
2.75.
is not very hard. Give a 2.75 and then we can post it in the left main area.
Proximally with additional 1
33.
millimeter.
33.
The question comes in, do we put a little more stronger antiplatelet therapy on this patient? Although PRU was 150, which is good, was on clopidogrel. We were thinking that after left main, because he has no other contraindication. So I would definitely, my usual dose is that you give 30 milligram loading dose, because those who are on maintenance of the clopidogrel, you give 30 loading, and your maintenance is based on your weight. More than 100, we give 10. Less than 100, we give 5. So this patient will get 5 milligram based on the weight less than 100, particularly in this case. Now, a lot of people ask us that question, that where are the data? We actually have 3 publications on this. The low dose, 5 milligram is safer, less bleeding, and if you follow the same protocol. We actually had the protocol in the past, 3 stents. If you have more than 3 stents, which is very rare now with the 48 millimeter, but 3 stents and weight of 100 kilos. So, well, how did you get to 100 kilo?
Okay,
Well, we actually did pharmacodynamic PRUs early time, and we found that once you're 100 kilo, your 5 milligram maintenance patient doing next day was not enough.
Now die.
So, 100 kilogram is our cutoff.
Anu, a
think you're
quick
right.
question,
Yeah,
which
yeah.
is the stent you're using?
Zions.
The
33 is a
Giants.
Zions.
Samin,
yeah. Okay,
excellent
I'm going to pull
question
back
here
a
for
little
you.
bit.
Yeah,
I'm going to
Okay,
read
some
it
dye.
exactly
Okay.
as posted.
good.
Okay, go.
Is there any difference in the technique of provisional drug-coated balloon PCI for the side branch between left main
Good.
and non-left main bifurcation PCI?
Down.
Not
This is
really.
2.5.
Basically the main issue is that you do your good result of the side branch first and do the DCB. You say, well, we can do DCB after we have done the main vessel stenting, and we go through it, open the ostium, and then do the DCB. But you know, the recommendation is that side branch DCB, if you do after stenting the main vessel, have a chance of scraping, because you still have to go through the struts, and so that is not recommended. Now, sometimes you may have to do it. There's a different story, but plan should be that you're doing a DCB before, looks good, then you do the DCB of then you DS in the main vessel. If does not look good in the side branch, you stent first. Now you technique, whatever you want to do, Then you stent and then follow your 2-stent strategy.
Where?
Okay,
That's
3.5 to 12.
Everything,
That's a healthy
everything
pinch.
looking good. Yeah.
Very good.
We showed how we did it. We did the cutting balloon,
Yep.
okay,
Yep.
and then we went with the regular balloon, did 90 seconds
Yep.
to, like I said, 90 seconds to 2
3.5,
minutes. And after that,
Yeah. No, but question was the DCB first of the side branch, then the main vessel stenting. Do not do the DCB after the main vessel stenting for the side branch. No, but that's the paper. There are many papers on that
understand
issue.
paper, but
And the technique of the bifurcation, there's a one randomized trial, and that randomized trial used this strategy also.
What
That you do
size?
DCB 3.5, 10. or 12.
Look at the
Yeah.
origin and the appearance angiographic of the ostium of the diagonal. Are
Yeah.
you
Let's see.
satisfied?
Yes, 100%.
The question there is, you remember all have shown, as long as you have good flow and angiographically less than 70%, this will be a FFR negative. Now, if once you start getting 75, 80+%, then you are in then you have to worry about. In this particular case, I would go even for 80%.
90. Actually, in
Or
the
90,
bifurcate, we
yeah.
say 90. Don't
90.
go to the side branch until that side. It is TB2 flow, 90% side branch, or chest pain EKG changes.
Which is none of them so
None
far.
of them are there. You can look at everything. Hemodynamics looks excellent. Should never go behind those branches.
Now take the wire out. Once you're doing a post dilatation, there's no reason to leave the wire. No, don't go
I
up
was,
here. Yeah, remember there's no
just,
reason to leave the wire now because you're not going to dilate at that level. So always I say if you do post dilate, take the wire out, recross if you need to do. In this case, not needed. You want to do the stent
No.
boost
Yeah.
to see you're covering proximal? Show everybody, they'll love it.
They probably use stent boost anyway. I don't use GOP.
Okay. This is a 3.512,
Yeah,
right?
yeah.
Yeah. You can go 20 here.
No.
No?
Don't
What is
go
the left
crazy.
main size?
No, left main is forward, LED is not.
Okay,
18. Okay, we can IVUS, that's it.
good.
Go here, 8. There's another D there, so D1. Okay, good. Down. Can you find Swati?
So once a patient wakes up later, give 30 milligram of Pressagul.
Okay, let's IVUS,
Yep.
and then we can do a final.
No, but you want to take a picture now with the vasodilator. Always,
No, sir, I know.
I
But,
could say the chemical stent.
you can
Give
do it.
ton
but I
of
mean,
vasodilators.
if we are doing imaging, we try to avoid. If everything looks good, we do a final picture and come out.
Okay, very good, very good.
Good.
But you can give a little vasodilator now. Where you cause little spasm. Actually, a lot of people decide just based on the imaging what to do. Are you successful, not successful? But we are far away from there.
Not we. You can use the word me, M-E.
Yeah. And after
When
that,
I use imaging, I will use imaging, but I think most of the time, if you are using our EYE, then we may need to do angiogram after you're stented.
Good.
100% agree. So we are distal to the stent.
Yeah, can you show the IVUS on the screen?
bring the IVUS on the main screen.
Okay,
Good.
start to work. It's kind of distal LED, small vessel. Yeah.
Nice transition, beautiful.
Yeah, it's kind of under.
Right?
It's kind of under. Opposed to the plaque, left main. Yeah,
Beautiful.
transition looks good. It didn't
Yeah.
come to the ostium.
But
I
the
will
only
stop it.
question is at the level of the second diagonal, should we dilate with high pressure trio?
Yeah, that's the point.
Go to
So-
the beginning where there is a diagonal
Yeah,
there.
so this is a distal edge. Now come to
Yeah,
proximally. So this, I see the diagonal from the 4
Right.
o'clock.
See here, there's still,
Yeah,
the
kind of
human is
under.
good, but it's still a lot of,
Yes, even the MSA is 4.6, but here the vessel size now expanded to like more than 3, 5.
Yeah.
So kind of under expansion.
so you can get a trio. We don't want to go to high pressure there. So give us a
No,
308.
hold on. What was at the level of D2?
Level of the D2,
4.5
the vessel size, stent area is 4.6.
You want to get a 5.5 here, minimum.
Yes,
Okay. If you do that, we may compromise the branch.
that's
No,
also
but
the
point is
issue.
the LED is the more important for long-term prognosis for this case. Here you have your data. Less than 5.5.
Yes.
No,
Right there.
that's okay. Let's have the optimal optimization of imaging is only in 50-55%.
No, but angiographically show the picture. You're right. So let's see the IVUS.
EYE. Get the
EYE
slide
was,
of the EYE. See? What would you say?
actually
Forget
at the
that.
diagonal there is still clear cut
which,
narrowing. Yeah.
which is what I thought. That
Yeah.
was my
I think that's the tightest lesion at the bifurcation. Now,
right.
clearly
That
you'll
the
compromise,
ostium.
but right now your LED is, sorry, D2 looks fantastic.
No,
Looking very good.
I'm telling you, my eyes, I would leave it alone. You can post dilate it and D2 will be bye-bye.
Now my question was
Hmm.
that are we reacting just to the IVUS finding or angiographic finding? I would say based on the angiogram, let it play. That there is, and then it's corroborated secondly by IVUS. But angiogram at that level, which is the tightest lesion, there is 20% narrowing. 20 to 30%. So you need to just dilate 3O, just there. And if you that much concern, put up, no, not put a wire in the diagonal. No. Actually, some people are even doing imaging after DCB, which to me is the height of craziness, which a lot of people do. But to me, AK, I think this area of the LED is under expanded. That's the most prognostic factor for this patient. We should post dilate there with a 3O. And 20 atmosphere, that short segment. Give us 3O. 8 or 12, whichever we want. 8
You
is
remember you have the reflex, angiographic reflex phenomena. You're reacting to the IVUS.
Nope.
That's it. For me, I
No,
would leave
because
it
you
alone.
didn't show the angiogram before. I would have said do the dilatation and then do the imaging.
No.
We could have predicted that result.
0.
Less than 5.5
Okay,
based
be
on the
ready.
angiogram. You can take
Okay,
another
take
picture.
another picture.
Magnify a little bit more.
Okay. Okay. This is the poor man's IVUS.
Yeah.
Don't give
Or you
dye.
want to do the
Give dye.
stand boost also? Just there. Just bring it here. 8 millimeter there. At that level, nothing will happen to your diagonal. Okay, let's do this one, and then after that we are done. We go to our presentation quickly. But we just want to make sure that by this we did not compromise the D2 blood flow. And all the data I have shown, when you do the bailout DES, after deployment of DCB, the event rate doubles. Because that's a phenomena of, in my opinion, higher drug concentration.
Go up. Okay, down. Get the IVUS. So I'll be happy. Go up here.
So, angio, that's no compromise, and we
Down.
just go to our presentation. All right, so any questions from our audience in the Hatch auditorium, our 50 plus fellows?
Samin, they are watching on YouTube and may not be able to ask us a question, but I'm not sure.
No, but why?
Danny is here today with me in the control room, and he mentioned, but you know,
Go up here.
there are
But they can go to CCC Live or YouTube anywhere, right?
Yeah, but they are watching on YouTube there in the Hatch, but
No, but Hatch is not direct relay,
Okay,
huh?
down.
I see, okay.
they
But
need
they
to
can
type
ask
in the
question.
question. Yeah, they need to type in the question, and
Okay.
we'll
Okay,
try
get
to
the
answer
IVUS
all.
quickly.
Done? Okay.
No, I'm
Let's
doing
go to
IVUS,
presentation
final
now. Have you
IVUS.
done the angio? Yeah.
You're done,
Good.
done.
So we go to our presentation now. Let's go to presentation mode. And this is basically we corrected. How do you like that? Little mistake. So with that clearly appropriate, this is a low risk left main disease. So clearly people have said that osteal low risk left main is okay, appropriate for PCI also by the latest guidelines. And then, so we come back to what we are going to show today. Recent international publication, part of that we have discussed, IVUS OCT or angiography, guidance during PCI of the complex coronary lesion, the network comparison of the limbus or paclitaxial DCB, and the latest DES or balloon angioplasty during PCI, and action registry. So we have
And it
DCB,
still within the
DES or
stent.
BA.
Within the
And,
stent.
and the last one is adjunctive imaging and physiology during PCI. Role of adjunctive imaging alone, the question which was asked, or physiology alone or combined, trends, outcome and cost. So let's go to our first one, which is IVUS, OCT or angiography in the complex coronary lesion, because few negative trials, even in the Renovate complex, which are complex PCI, up to 3 years they have a benefit, but then there were 2 negative trials even of the left main, which came out in the ACC, optimal trial and so. So basically is that IVUS versus angiography, OCT versus angiography, IVUS or OCT versus angiography, and IVUS versus OCT. These are the trials which are part of this network meta-analysis. Most important is any type of complex, whether it's a severe lesion, left main, CTO, bifurcation, severe calcium, long coronary lesion, multivessel disease, you can see clear-cut treatment of the imaging favors compared to angiography in all complex lesion subsets. So there is no interaction. There's some angiograph does not work. Now this is actually the central figure, which is a patient 17 randomized trial, 13,000 plus patient, primary endpoint was major adverse cardiac event, and you see the network plot. So league table basically showed that IVUS is better than angiography, as you can see, and then OCT is also better than angiography, but both IVUS and OCT are identical. So outcome, whether you do IVUS or OCT is identical, but IVUS and OCT is better compared to angiography to decrease MACE in these complex cases. Second point. So therefore, until additional and more granular data becomes available, the network meta-analysis by Carvalho et al. Provide reassuring evidence that the clinical benefit associated with intravascular imaging over angiography alone are consistent across multiple complex settings, irrespective whether IVUS or OCT were used. So clearly, highlight the case which we did today. Complex case, imaging still will stand despite the 2 negative trials recently. Then second is which drug-coated balloon strategy, Limus, which is sirolimus or any Limus. We have data of the sirolimus, our Limus is not there yet, and paclitaxel, and comparing with the newer drug-eluting stent and balloon angioplasty, another network meta-analysis, and basically showed that here, as you can see, Limus DCB versus DES, kind of same. The DCB is better than POBA, and paclitaxel DCB is again better than POBA. So so these are the network analysis. So this puts it together that Limus or paclitaxel DCBs are identical, no difference in the outcome, and they are good with a second generation DES. You see that unity is little on the side of the DES, and that is largely driven by the large vessel DCB. Now, they also have shown that once you have the event rate follow-up, which is the most device which is helpful. So if you're talking about the de novo CAD, in this study, Limus DCB has the lowest chance of myocardial infarction, and the POBA has the highest, as you can see. And second generation DES comes in between, paclitaxel also in between. If you talk about the revascularization, then the stent DES is the most on the top, others come lower. So this basically is put it together in this cases that no significant difference are observed in MACE or its component between Limus and paclitaxel DCBs, albeit with limited statistical power. Furthermore, DCB and second generation or newer drug-eluting stents yielded similar outcome, though power are limited, especially for de novo CAD. So therefore, is this a class effect? It seems to be at this time, but we need to follow some more data. There is a very nice publication which I just used one slide of this case is the DES drug-coated balloon angiography versus drug-eluting stent implantation following rotational atherectomy severely calcified lesion from Japan. Actually, we are planning similar type of study. It is just basically showing that your DES has a better outcome compared to DCB after rotational atherectomy. So that's a very good message, although this field still need to be explored by other trials. Then there is another data that is cardiogenic shock. So we know cardiogenic shock has a limited, clearly 40-50% 30-day mortality. Can we decrease it further? So this study took the intravenous antiplatelet therapy in acute MI with cardiogenic shock called action register action study. Use the cangrelor or 2B3A. This basically was antiplatelet therapy versus no antiplatelet therapy. Cangrelor was used in 23, GPI was in 83, some of them were overlap. And what they found basically that overall by using these agents, you had a little better TIMI flow, which we expect. And say more importantly, the most common antiplatelet therapy used was ticagrelor, and of course that P2I, initially, and then of course you did the switch, and switch again happened ticagrelor in 2/3 of patients. What are the outcome? That by using intravenous antiplatelet therapy, your MACE rate decreased significantly from 45% to 29. P-value less than 0.01. 30-day data, and therefore even lower mortality and ischemic stroke. Now this is, you can see, ischemic strokes is lower, mortality is lower, MI is trended, and more important, stent thrombosis. I was surprised. The 3.5 stent thrombosis in the antiplatelet therapy is still high. We don't see that, but main was 7, so p-value was not significant. So stent thrombosis was no different. And if you take only the bleeding, and you can see, despite IV antiplatelet therapy, there was no difference in bleeding. It was 42 in the no IV antiplatelet and 34 in the IV antiplatelet. Why it was lower in the IV antiplatelet therapy, I read through the paper, and they just cannot explain that. Individual endpoints based on lower age, male, female, STEMI, non-STEMI, everything was consistent with the benefit of IV antiplatelet therapy. So this is the central figure showing it together, that better effectiveness, similar safety by using IV antiplatelet therapy, so that in acute MI cardiogenic shock patients undergoing angiography, IV antiplatelet therapy was associated with a lower ischemic risk without an increase in major bleeding at 30 days. Little surprise, and this actually very nice editorial by Dr. Bhatt on this point, that adding 2B3A, which kind of has come out of our equation, should be, right now should be 2A, because we don't have the class 1 indication yet. But thus we had to think about, particularly many of these patients not able to swallow, and they don't have a good absorption. Then we go to our focus review, that is combining imaging and physiology. What are the trends? These are the Medicare beneficiary, adjunct imaging and physiology during PCI in United States. And you can see here what is happening. The yellow line, the blue line, which is the intravascular imaging, is going up. Then physiology, you going down, but many of those cases then combined. So therefore, none is done in less percent of cases. So basically, I would say about 25% of cases now are getting, or 20 to 25% cases are getting imaging or physiology in the United States. And this is the individual, where use, which have the IVI, IP, or both. And actually, if you can see, that patient with a left main disease, and that was the question asked. In left main disease, LAD, you many times you end up in doing both, higher number. And lastly, that large hospitals and academic hospitals and inpatient, you combine both the strategy more than otherwise. And individual, you can see here, use of both IVI and physiology during PCI. They have adjusted ratio, and clearly on the right side, more number happens, as we said, patient with a left main disease using atherectomy and lithotripsy, and patients who are being done at the large institution. Now, what is the outcome? As you can see here, the lower outcome with a dual and invasive physiology. So key that none or IVI on the top. None on the top. Second blue line is your intravascular imaging, and then combining both or physiology is lower. So seems to be combining both gives you better results, or alone you can say, like this one shown very clearly, that once you combine imaging and physiology, or you do physiology, outcomes are similar in every aspect, and they are better than not using them. And this is now very important points. They also wanted to see what is the cost. And the cost basically is, when you use these devices, your index cost is higher. We expect that because you're using this IVUS or imaging or physiology. So yes, but then benefit occurs later. Repeat revascularization goes down, either out of those three strategies, and hospital readmission goes down. So therefore, charges become lower at follow-up. So this will be a benefit to the public safety and to the insurance company, but not for the hospital. Hospital, you are still doing the more costly procedure. And that's why one of the use, despite the adequate reimbursement, not in all, that our imaging use or physiology use is lower because of the higher initial cost. And this is a very nice depicted central figure, intravascular imaging, clinical outcomes and physiology. And you can see here that best was the dual or physiology. Now on the right side, you see the cost. At index PCI, higher cost compared to angiography, but 2-year post, lower cost compared to angiography because of lower readmission and repeat revascularization. So this basically we learned from that. And this is also very nice editorial that combining imaging, physiology, and then combining, which makes the maximal outcome benefit, lower long term cost, emerging role of angiography based physiology, and potential of intravascular imaging derived physiology. So it's what they're trying to say, that now there are a lot of data have come that imaging guided just by angiography you can do FFR. So maybe that will decrease the cost. And of course, both of them have equal their role. So let me just go quickly. Imaging, IVUS or OCT or angio for lower MACE in complex lesion, yes. Ramus or paclitaxel DCB versus current DES, which is a little better, equal MACE at 30 days, yes. And then IV antiplatelet therapy or control in acute MI cardiogenic shock at 30 days, real benefit. Also decreased bleeding, which is surprise, but that's what they found. And then lastly, the penetration of imaging and physiology occurs in only 20-25% of cases in USA. Dual use is more beneficial, slightly increased cost initially, but long-term lower cost because of lower revascularization and lower readmission. So let's go to our questions. Following are the true statement regarding the results of the action registry for acute MI shock, comparing IV antiplatelet therapy versus no antiplatelet therapy, except lower MACE with IV antiplatelet, lower death rate with IV antiplatelet, trend towards lower bleeding with IV antiplatelet, lower stent thrombosis in IV antiplatelet therapy, and lower ischemic stroke in IV antiplatelet therapy. Then you saw it. There was no difference in stent thrombosis. Statistically, although p-value was non-significant, although it went down from 7% to 3.5%. So D is not correct. Second, following are the true statement regarding the comparison of IVUS, OCT, and angiography in complex lesion, except similar MACE rate in IVUS and OCT versus angio, lower MACE rates to OCT versus IVUS, similar MACE rates with imaging in various complex lesion, lower stent thrombosis rate with imaging versus angio, and higher procedural time with imaging versus angio. Clearly, answer is B. B is wrong. There is no rate. Only Octivus trial showed OCT and IVUS have a similar outcome. There is only one trial which has compared OCT versus IVUS. Lastly, following are the true statement regarding the use of intravascular imaging, physiology, or both, or none during PCI, except lower follow-up cost of PCI with imaging, lower hospital readmission with IVI and physiology, lower index PCI cost with IVI and physiology versus none, lower repeat revascularization with IVI, and combines one IVI and physiology is done in more often in left main PCI. So answer there is index PCI cost is higher, not lower, once you use the imaging and physiology. With that note, I complete my presentation.
I mean, excellent presentation as only you can do it. Just superb. I don't think operators should be at this stage be overtly concerned with the cost, because they'll all come down. I am happy today to talk to you about an initiative which I have personally watched over the last almost 15 years. The topic of women in interventional cardiology, it is so critical, because we simply cannot be doing all these procedures with such booming applications around the world, in China, India, so many countries, without active participation of women. They are such an important part of it, and I can attest to it that as far as I'm concerned, and look, I've had my share of proctoring angioplasty all over the world, I see nobody who would even come remotely closer to Dr. Anu Kinney. And I mention it for two reasons. Number one, I have watched you, Anu, over 17 years, 204 cases. Nobody has the skills in interventional cardiology like you. I mean, I think you don't even have to restrict yourself with women. You are absolutely the best, and it is depicted by the following which CCC Live has. I think your second contribution, which got spoken today, and I want to emphasize on it, is that the pathway which you have created here to personally, I mean, look, one aspect is to talk about it. Look, we want to encourage women in interventional cardiology. You have actually led that life and have an active program. Share with us what you are doing for training women in interventional cardiology.
Okay.
And we are coming out now.
No, no.
Look, Sameen, on a very serious note, I'll tell you, the entire progress here, and this has happened because of you. You know, because you felt so assured. There was never any doubt in you. And I mean, Anu was your fellow 25 years ago. So the entire movement also owes because of you. So Anu, take us through this initiative. I want the entire interventional cardiology community to recognize your efforts in this direction.
Yeah, thank you for this introduction. Yeah, I know Dr. Sharma was walking away. We pulled him back. I said, don't go too far. Yeah, I will say this is a 2026. It's 30 years, okay, since I put my foot into the soil of United States. And I'm very proud that this country has allowed, you know, for me to be where I am.
Having said that, as you know, even in India, the women interventionalists are single digits. It's still like less than 5%, and we try to encourage as many as possible. They just don't, you know, very few have reached to the level that they are moderator, they are complex operator. Actually, I have never seen an Indian interventionalist, women interventionalist doing a you know, intervention, particularly in the major cardiology events.
Sameen,
Okay, so
this
I
is
will tell you
yeah,
about my
yes,
journey
Anu.
now. So of course, from England, then I decided I wanted to do intervention, and then how do I get it? So it was my mentor there, Roger Hall, who actually made a phone call to Dr. Valentin Fuster. He knew him since Mayo Clinic. So he made a phone call to Valentin Fuster. Those days, you know, pigeon has to be mailed. There was no email, had to be phone calls. And that too, no cell phone, had to be landlines and writing letters. So then we had to write application to all the fellowship programs in the USA. And I think Dr. Fuster sent which he does even now, sent my file or a few papers to Sameen Sharma, who said, okay, let me do the interview. Interview was at 6 a.m. in a Holiday Inn in Anaheim. Yeah. This was 1995. Okay. So then that's where we met. And he said, you'll be the first. I was the first woman fellow to be coming to USA as a non-ACGME. Okay. Non-ACGME. He said, it will be a non-ACGME. First time we are doing it. We don't know, but I'll try my best. He was at that time, I think, associate director. He was not the director of the cath lab yet. And he'll try his best to get me here. And they didn't have funding. I said, no problem, what? I will come. So I landed in United States with 7,000 pounds. That's it. Okay, 7,000 pounds, which is, you know, from United Kingdom money. So that's how I landed here and did the fellowship. And after I did the fellowship, we decided that I'm going to stay here. That's a long story. I can write a book of things that how hard it was in those days. So this was, if you think right now, if you talk to people, even now it's very hard. 30 years ago, it was way harder. But I could not have done that if not for Sameen Sharma supporting me. So not even did he train me. Even now, you know, one thing about him is if you think you're good, he lets you do things. So he allowed me to do things and allowed me to grow to become what I am right now here. So he continued not mentoring, fostering, and most important is he realized, okay, this person is talented, she has the skills, and allowed me to grow to where I am. So going back to the point, it's not women. Where I am today is not just supported by women, it was mostly men. And one other person that really pushed me to do everything was my father. Okay, so it was all men who pushed me to get where I am. Now coming back to the point, okay, I have reached here. And one other person that actually probably allowed me to become a director and subsequently, because he kept telling me in a teaching institution, those days may be very hard for you to be a director. But the CEO, Kenneth Davis, believed in me and said, yes, she's very good. Let her be the director. That's how Dr. Samir Sharma was able to then do his international activities. Okay, because you knew that is a strong person that can manage this place. So that's where we are. Now, I went through that. I was a very strong person since the way I was trained. It's all because of my dad. You know, I'm the only girl between two boys. Okay, I'm the middle one, but I was raised to become self-sufficient and confident. So I think that's why I am what I am, and people see that. I won't budge easily. Now I see that it's not that easy. I would not say that is the same. It's not easy for women to be in this field because one, it's the usual. You are in medicine, very hard work. And then on top of that procedure, you have to be good in the procedure. Your outcomes have to be good in procedure. Then you have to be good at what you are. So that is when I decided, okay, we need to help people who want to do it. Okay, first and foremost, they need to have the initiative and the desire. I want to do it. When I see that in any kind of a woman, yes, I will help them. I will not say that I don't help men. I do help this, all of them. I foster everybody, boys and girls, all of them. But especially I have a soft corner for women because I know what I went through. So since I have gone through it, I want to make sure they don't go through the same process. It'll be easier. Am I tough? Super tough. They know it. If they don't do it my way, it has to be my way, and I'm very tough because then I know that when they go out, they're going to be facing that kind of toughness outside. So they are ready for the outside world. So if you see here, look at
So before you go on to the, just want to say a few things, and then I'll give mic to one of our the fellow or attending. That few things which on what Dr. Kini has said, and to just to supplement on those. One is clearly every year when we get our fellows, all of them are here. The one of the things they ask that why you want to do it. He said, well, they want to follow Dr. Kini. That clearly they want to go on her footstep, and that is the great that somebody considers as a role model, and that's why the whole every year we have 1 to 3 women fellows for last many years after her initial one, she being there. And the second is it's your work speaks for it. You know, a lot of people talk. No, do your work and you'll get what you want. Basically, because it will come natural. And that is how she became the director of a cath lab and of course all the positions. And as of this month, so I am a director of interventional cardiology for Mount Sinai as well as for health system. She is director of the cath lab at Mount Sinai. So we are making her this year, starting maybe let's say July 1st will be the right time, director of cath lab and intervention at Mount Sinai Hospital. So I'm giving, she's well deserved. And the third one, as actually Samir says our story, when I was a resident at Beekman downtown, Samir was 1 year junior, and you knew exactly who I was. So in matter of fact, yesterday at Cleveland Clinic Foundation in London, I met her co-fellow, co-registrar, what I call co-registrar. They're working with the Cardiff at that time, and the Bernard Pendergast. And Bernard said she knew about it, her progress, and she said how she's doing this. He said back then she was very hardworking and wanted to complete the job quickly and at time. Not like people lingering. You know, here I said, take it easy. You know, we'll do all. Your time is less of an issue because I know I'll be here till midnight. But for her, tuck. But just to say that back then, we are talking about 94 to 96 before she came. That time, this guy said, Pendergast, actually, he's the chief of cardiology at CCF London, to say that how her work ethics and perfection was there back then. So these are the real added comments on this her achievement, and I'm very happy to her to be a part of our success of the cath lab.
So now the goal is like we were talking. Yes, it's just a talk, or do we do? One we say you walk the talk. So that's where we are. So I have Isha. She actually is were you a resident Mount Sinai?
Yeah.
Yeah, I know her since then. Then became fellow here, interventional fellow, and she stayed as an attending. What do you have to say? Tell them.
No, I think it's been a privilege and a blessing, honestly, to train with Dr. Kinney and Dr. Sharma. Dr. Kinney has paved the way for me. Before I came here, I honestly had not known any female interventionalist, and watching her not only lead this cath lab, but also lead interventional cardiology in general with her skills, with her confidence, with her just aura that she has, I think inspired me, continues to inspire me. I learn from her on a daily basis, and I feel very blessed to be a part of this family.
So we train them, and we also like to keep them. Then we have Maria. She trained, like I just mentioned, interventional fellow, structural fellow, and she's going to stay as a faculty here for us now.
Anu, today I think is the right moment. We've been wanting to do this for a while, and nobody has had a front seat better than me over the last 17 years. I have watched your progress. I say it emphatically, nobody even comes closer to women in interventional cardiology as per your skills, and not only that, to take that belief and train and mentor so many other people whom you have guided. And what I have been watching now, we are able to showcase to the rest of the world through multitude, hundreds of these live cases where people see your talent. And I think they owe it to you to have taught them so beautifully.
Anybody has to say anything?
Can I?
Yeah, yes.
It's on?
Please go ahead. Yeah, we can hear you.
Oh, okay. I'm
Photo.
Swati. I'm a two-year
Photo.
interventional fellow at Sinai. Because Dr. Kinney has gone through so many things in her own life, she gave me the opportunity of staying back for another year out of the kindness of both her and Dr. Sharma's hearts. So when I came from a different program, and I hadn't met any female interventionist like Dr. Randy was saying before. So when I first came here, the difference in culture was tremendous. It's taken for granted that women can do the same things as men. Like we can hold a sheath, we can do the case, we can stay till midnight. There's not even a subconscious, oh, are you sure you'll be able to do it? There's not even one day. Yeah. So, I mean, it's because of her. She stayed here, she stood her ground, she's shown what she can do. And because of her, we're, treated as equals. And it's a very grateful opportunity for me. So,
Swati, I have watched your growth, and what you're saying is so true. Look, it's almost fashionable today to talk about women in interventional cardiology, but right in front of me, I'm seeing 7 of you. And this is an entire pathway which has been created. Anu, congratulations to you. It's a lifetime of your work, of courage and determination. And yes, please, whoever else wants to speak, today is the forum. Recognize Dr. Kinney for her efforts and what she's doing for you.
Can you hear me?
Yes, we can.
Hi, I'm Sophia. I'm from a very small rural town in Mississippi. I pretty much stumbled into this spot and I couldn't be more grateful. Thanks to Dr. Kinney and Dr. Sharma for everything that they've done for me this year and teaching me. She has been an inspiration for me, Dr. Kinney, being a female in cardiology. Not only has she taught me her skills, but she has taught me to be a stronger individual and to stand my ground. I am a tiny person, but I feel like I've learned to be tough, and that's thanks to her. So thank you so much. It's been a great year.
Anu,
Okay.
you have lit an entire path. So many will follow your lead and succeed.
Thank you.
can I say something?
Good? Okay, thank you, guys.
Good luck to you all. We conclude our session, and we'll see you session number 205 on July the 21st.